All right, so before we start, this is part three of SNL, CRS, and I'm going to make myself big and I'm going to make a couple announcements. Number one, go to my YouTube channel. First, subscribe and like this video. Go to the YouTube channel and under playlists, you can find videos for um, other modules, other question banks. So this is SNL right now. I'll probably make one for IEA and for the modules in the future too. I'm going to try to do them for all terms and all modules. Okay, that's announcement number one. Announcement number two is that in the video description, I'm not sure what, but I'm going to put a way of contacting me. And if you have any questions, any inquiries or something, make sure to use that link and nothing else to contact me because that's what I check for this channel. Okay. If you have any ideas, anything you want me to know, use whatever is in the description. I still don't know what I'm gonna put. It's probably gonna be an email. All right. So we did 20 questions in the first two parts, but we're gonna get it a little faster. So question 29. Uh, by the way, the questions we skip are the questions that are renal. They have a R next to them. I'm gonna make another series of videos that are on renal, and it's gonna be on the same way you access it. Go to the channel, go under playlists, find a playlist for SNL, renal, uh, CRS, whatever, right? You know it. Okay, so this time we got a 45-year-old and has hypertension and is as a part of a drug experiment is taking an antidiuretic hormone antagonist, right? So these drugs are two type of drugs I can think of. One of them is Vaptans, so it's like a suffix. Conivaptan is one that I can think of. They basically antagonize the ADH receptor. The other one is demeclocycline. I don't even know how to write it, or honestly, I don't even know how exactly you say it. But this other one is a tetracycline antibiotic that has uh, ADH receptor uh, antagonism. Antagonism, right? So these two drugs are useful when you have SIADH, right? When you have too much ADH, you want to block that signal. This question isn't about that. This question is actually kind of a renal question, but you're going to do it anyways. It's talking about uh, what happens when you block this. So basically, the question is about physiology of what the ADH receptor and what ADH does. ADH, you gotta so on the distal convoluted tubule. So if this is a glomeruli, the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and then you got the collecting ducts, right? So ADH works in this last part, this part, and what it does is that it when you have these cells have these like vesicles in them. On these vesicles, they have these transporters. These transporters are aquaporin transporters. So when ADH and the cell has a receptor for ADH, when ADH binds here, uh, these vesicles will bind to the surface, and the cell will be expressing aquaporin now, aquaporin, and that allows for water to move from urine into our like blood. So it moves from the lumen of the vessel, and that's how it causes antidiuresis, right? So it reabsorbs only water. Uh, so the answer to this question is this one: decreases urine osmolarity, right? So meaning it makes more concentrated via taking out more water without a major change in electrolytes excretion, right? So this is our answer. But I want to spend a little bit more time explaining the pathophysiology or like the physiology of ADH here. And Oh, the thing I was gonna do is that ADH has two receptors, V1, and remember, vasopressin, I think, is another name for ADH, or is maybe the drug name for the ADH, the drug that we give. But vasopressin, right? Vascular oppressin contraction, right? Puts pressure on, right? Basically, it has two receptors, V1 and V2. Uh, the way I think about it, so you gotta know what each receptor triggers. Um, the way I remember it is that V1 is kind of like H1 from histamine, and V2 is like H2, right? That's one thing. The other thing that I remember, V1 has this one. It kind of looks like a long vessel, right? So it's on the vasculature and it causes vasopression, right? So it is IP3 calcium. So it's a GQ, right? So let's clear this up. So this is got to be a contractile. So it's a calcium, or let's just write a GQ, and you got to know GQ is IP3 and C2. And then V2, on the other hand, is a CAMP, right? And so the one that's expressed on these vessels right here is a V2. The ones that's expressed on smooth cells, or sorry, the smooth muscle cells of the vasculature is a V1. And so, again, how do I remember this? V1 has this one. It kind of looks like a vessel. It's called vasopressin. So it puts pressure on the vasculature. And what puts pressure on the vasculature in the context of smooth muscles? You gotta contract the smooth muscles with calcium, and calcium is a GQ. So through these sequences, like what I have to memorize, like I didn't remember any of this before I started explaining this, right? What I remembered was that I know that the one and kind of like a tube, like a vessel, like that's the one goes with a vessel, and then from the vessel I kind of like derived everything else. And so your goal with memorizing medicine in general should be to know everything with memorizing the least amount of information possible. So for me, all I had to remember was that the one, it kind of looks like a vessel. Through that, I can figure out the one has to be a GQ, and then the V2 has to be a cycle AMP, right? And through that, I can also remember that the V1 and H1 are the same. And so the H1 is also a GQ, and the H2 for histamine has to be a GS, just like how V2 is. And just a review point, do you remember where G1 is? Sorry, do you remember where H1 is and where H2 is? I'm trying to think myself. I think I don't exactly remember, to be honest with you, but I think uh, H1 histamine is the one that's on the gastric cells. I think not, yeah, the parietal cells, and it simulates. Actually, I think I'm right. Yeah, I don't exactly know, but that's how I remember even like what the H1 and H2 do. So again, your goal is to know the least amount, like memorize the least amount of thing, and be able to like drive a lot of things out of it when you're like kind of like trying to memorize these things. Okay, 39 is a endocarditis question. Got a 7-year-old boy, abdominal pain and bloody diarrhea. Okay, you haven't gone through DERS, but this question can also be a DERS question. The son of a current SGU student. Uh, ate some beef, right? Beef is associated with certain types of infections. And then we got this disclaimer here. Blood smear shows as schistocytes, right? I'm going to talk about what those are if you don't know what they are. It's important. And then we got increased LDH, we got decreased hemoglobin and platelet, right? Okay. So, and then Hmm. Okay, so I don't know if you've learned this or not, but I think it's a good question because you can explain a lot of things with it. So, bloody diarrhea, you know, uh, so you don't need to know any of this. What you need to know is to recognize what a schistocyte, which is these guys, it's called helmet cell. If you look, it looks like a helmet. It's basically, a cell looks like this. These guys are a cell that's cut literally from the center, right? So sometimes they got these little tails here, like you see here. So these cells, what happens is that if this is your vessel, some for one reason or another, you get activation of platelets. So platelets get activated and they bind here and they form like these, I don't know, like irregularities on the small vessels, right? Vessels. So microangiopathic, right? Got the micro here, and then so these cells get sheared through these. So they imagine the pressure is it's not, well, let's draw a bigger cell so it becomes more obvious. And in the super small vessels, the cells are this big. They're barely fitting through these capillaries, right? So this cell gets sheared through, that gets cut through, and makes a helmet cell. So it's getting hemolysis. It's hemolytic anemia. So we got this thing, and so what I described here, like these small plugs, in unsmall vessels, cutting things in half, is known as this thing, microangiopathic. Oh no, microangiopathic hemolytic anemia. Microangiopathic is in small vessel. We got hemolysis, and therefore we get anemia. So what can we explain through this? We can explain schistocytes, decreased hemoglobin, decreased platelets, increased HDL. HDL is an enzyme that's in these cells, right? When you burst them, some is going to get out. And then there's this thing called hepcidin. No, not hepcidin. It's something else. Heptaglobin. There's this other molecule that sounds like these two, and it binds hemoglobin when hemoglobin is freed from RBCs, right? It sounds like something like heptaglobin. I'm not exactly sure, but in a context of hemolytic anemia in general, specifically, that molecule's concentration also goes down, right? It's not super high yield for SU. It's just important for you to know that things like that exist, right? And you'll probably see it in like a U World question, and it clicks in. Again, I don't really like memorize the names, but I am able to recognize them. Um, okay, so all these are explained by it. So now, why does this happen in the first place? The reason this happens in this case is because there is this bacteria that is in enterohemorrhagic E. coli, right? Or E. coli, which has serology of 157H7, right? This serology is important because it's associated with this, right? So this type of E. coli has a specific toxin. It's called a Shiga-like toxin, and Shiga-like toxin likes to cause problems for the inside of vessels. So it causes like little damaged areas that then platelets can bind to. Another situation where this happens is called um, TTP, thrombotic thrombocytopenic purpura, right? Thrombotic thrombocytopenic purpura, right? Let's analyze this name. Thrombotic is referring to the fact that we are forming thrombi like this. Thrombocytopenic is referring to the fact that you're using all the platelets here, so you get decreased platelet counts, right? Purpura is an interesting term. It basically means small vasculitis, right? So it basically means um, you'll get these like kind of petechiae like bleeding lesions because you're thrombocytopenic, right? Uh, so And here the pathology is there's this protein, atom 13 or whatever, something like that, that this protein is responsible for cutting down VW factor. And then when this protein isn't working, you get like high amounts of VW factor or something like that. And then you get to the pathology of like over clotting, right? So, and interesting to know that the Shiga-like toxin, what it does is that it messes with the atom 13 protein. But the people with TTP, they have like a mutation in atom 13, and not having atom 13 causes you to just do this stuff, just like start like having your platelets form these little kind of spikes that end up tearing plate cells off. Let's go actually and check our answers as we go through, because I don't want to have something wrong and then look like an idiot, like trying to logic myself into a wrong explanation. So our 29 is right, C, right? And this was 39. Yeah. So, oh, and again, TCP. So, remember TTP? Is that entire thing? When it's caused by uh, enterohemorrhagic E. coli, we call it hemolytic uremic syndrome. I guess I completely forgot, and you actually not big things, but two things. One about HUS and one about TTP is that TTP tends to give neurological shit like symptoms. Uh, right? And HUS hemolytic, you got that uremic. So if this guy hits the kidneys hard. So here we didn't see anything, but usually you'd expect like a creatinine rise or something like that. Um, yeah. All right. 40. 24-year-old presents with the ER with palpitation. Okay. He experienced something like this 1 year ago. Pressure is normal, but pulse is crazy high. Uh, So they give him something that so it's kind of an arrhythmia that just starts. This the fact that it just starts out of nowhere is known as paroxysmal. Right, that's just something to know. Proximally starts having high heartbeat, and it's probably a proximal supraventricular arrhythmia, right? Which basically means proximal means once in a while, but when it starts out of nowhere. Supraventricular means it happens in the atria. So if this is the heart and this is the atria, so there's a aberrancy. There's an aberrancy of signaling here that like instead of originating from the SA node is just like, and this is the AV node. So this guy is just like self-feeding itself and then is feeding down into the ventricles. The ventricles are totally fine. Whatever is wrong is within the atria, right? But the point to know here is that you get flushing, burning chest, and dyspnea, right? So the drug side effect is flushing. Right, that just makes me think of adenosine. To be honest with you, that's literally what I see. It's a very unique side effect. I'm not the best at antiarrhythmics, antilipidemics, and uh, anticoagulative agents. I'm really crappy on those topics. But I know like basic stuff like flushing causes is from adenosine. To be fair, I'm okay with anti-lipidemics and anti-arrhythmics. I really don't know crap about anticoagulatives. So maybe if you see a question there, I'm gonna have to pause it and like look up what's going on. I just didn't study that well when we were doing CPR. 57-year-old presents to the physician. So for some cough, uh, he's type 2 diabetes, hypertension, heart failure, hypocholest- Hypocholesterolemia. I don't know. Maybe hypercholesterolemia. That makes more sense. And heart failure again. Oh my god, this guy's heart failure twice. He currently takes albuterol, theophylline, metoprolol, ACE inhibitor, hydralazine, digoxin. What is it? Oh, he's got some cough. Okay. I mean, like this question, and I saw theophylline, and when I saw hypocholesterolemia, when I saw heart failure twice, I thought it's not a super well written question because theophylline is rarely used. Hypocholesterolemia, um, I don't even think that's a thing, right? Heart failure twice, so it's just like not a well written question. But what it the to summarize it is that one of these drugs is giving him a cough. What are we going instead? What gives you a cough is ACE inhibitors. ACE inhibitors, right? Now, it's not important to know that it gives you a cough. Of course, you got to know that, but you got to know why, right? If you know it gives you a cough, you're going to answer 80% of the questions on this topic. But if you want to get the rest of the 20% questions on this topic, you got to know why. The why is always really important. So, the ACE inhibitors, they inhibit an enzyme called angiotensin um, convertase, right? So this, I'm not even gonna write it down. I don't know what it is. It's enzyme angiotensin convertase. What it does is that a lot of times, so one of the things it does is it turns angiotensin 1 to angiotensin 2. Also, the other thing to know about it is that it's in the lungs, right? It's in the pneumocytes of the lungs, right? This literally is where it's located. One of the other things it does is that it breaks down bradykinin, right? Bradykinin to, I guess, destruction, right? So when we inhibit it, we're increasing bradykinin, right? And this leads to the cough, right? So that's why we got to stop this and start something else. What we can do is that we can give him an ARB, right? So ARB doesn't work here, doesn't do anything with bradykinin. When angiotensin 2 wants to bind to its receptor on a cell, ARB, this is our ARB, binds here and blocks it, right? So we stop on our drug that ends with pril and then give something that starts with sartan, right? So the one thing you got to make sure is that, first of all, I'm not going to mention it now, but there's also the nephrolysin inhibitors, that those drugs inhibit an enzyme that enzyme uh, uh, ANP and BNP, right? Atrial natriuretic peptide and brain natriuretic peptide. So this enzyme, the nephrolysin or nephrolysin peptide, breaks these down, right? And so when it's inhibited, we get high AMP and uh, high AMP, and the AMP is really beneficial for heart failure. Same story here. When this is blocked, we can't use an ACE with it, so we use an ARP with it. Right. So answer to this, but I'm gonna explain the case of the nephrolysin question when we actually see a question about it. It's not a super important concept, but it's like the same overarching concept. So we got D or yeah. Question number 42. 36-year-old is complaining about her chores. So medial hypertrophy, intimal fibrosis, and decrease interluminal diameter of the small branches of the pulmonary artery, right? So medial hypertrophy one, intimal fibrosis two, and well, actually really those two things. These are kind of like characteristics of what? They're characteristics of pulmonary hypertension and the type that's kind of like idiopathic and has really bad prognosis. So when I read this question, I felt a little sad because it has really bad prognosis. There's not much you can do about it, right? But one thing you can do that doesn't help that much, but it's still something, is to give him A, right? To give him budesonide. And remember that budesonide is an endothelin receptor antagonist. So it blocks endothelin. But one thing it does is that, so basically, what does endothelin do? Remember, or maybe you don't remember, but when we are getting blood coagulation, which I'm sure most of us have already forgotten, one of the very first things that gets activated is this endothelin receptor, and that causes constriction of the vessel. Right. Every time I draw like a ring around a vessel like that, it's supposed to be a 3D ring, and it's like representative of a layer of smooth muscle, and it means constriction. Right. So it endothelin activation of endothelin results in constriction, but also so these guys have when we're blocking endothelin receptors, we're kind of like relaxing those vessels. But the other thing that's useful for these guys is some sort of a phospho di- like a something like a sildenafil, right? Um, that will increase CAMP. I remember I said CAMP in the vasculature means relaxation, but it's a really bad disease that has poor prognosis, and yeah. So the answer is A. 43. A patient is admitted to the emergency department after a drug overdose, right? Uh, Hypotension and severe bradycardia. What sort of drug is he on? Uh, he has been receiving, oh, it's not a fun drug, it's just a therapeutic drug. He's been receiving therapy for hypertension and angina. Uh, which of the following in high doses causes bradycardia? Okay, so something that's got to cause bradycardia. I see we have brapamil here. This is a non-dihydropurine calcium channel blocker. So the difference between dihydropurine and non-dihydropurine calcium channel blockers is that the dihydropurines, these guys are more in the smooth muscles, but the dihydropurines are more in the smooth muscles, but the non-dihydropurines, these guys are more in you tell me, they're more in the SA node, just in the conductive tissue, right? So remember this thing. I don't even know how it works. This is the SA node action potential. It's got this like, oh, wait, no, that doesn't make sense. It's got this slow raise phase and then fast raise phase and then goes down. And again, slow raise and then fast raise and then goes down, right? So this slow raise is done through calcium, right? And actually, so is this. But the these guys, they bind to L type. I think it's L type calcium channels here, and they kind of extend it so that instead of looking like that, it looks like something like this. So it like they increase the slope here, and that widens the space, right?